Hi, my name is Mark Bicket. I'm an assistant professor in the Department of Anesthesiology and Pain Medicine at the University of Michigan. Today I'll be speaking with you about COVID's impact on the treatment of opioid use disorder. We'll start by talking about changes in opioid use disorder treatment during COVID-19, and then speak a bit about the impact of COVID-19 on that treatment, as well as the impact of telehealth for opioid use disorder. So first, changes in opioid use disorder treatment as a result of COVID-19. It's important to recognize that there are several different types of treatment as it relates to opioid use disorder, and ways in which that's often measured in studies that are done related to opioid use disorder. One way of examining studies is looking at medications, and those largely include buprenorphine, methadone, and naltrexone. Another way of measuring the impacts of service as it relates to opioid use disorder are ways in which treatment programs are provided, and those can include opioid treatment programs themselves, or the results of urine drug testing. Here we'll look at changes in opioid use disorder treatment during COVID-19 as it relates to some of the medications for opioid use disorder. So annually between 2012 and 2021, we see at the top of the graph methadone as a treatment, and we see at the bottom of the graph buprenorphine in the darker line. Here's quarterly data as well for a more granular view between 2019 and 2021. The big takeaways are that methadone experienced a decline in terms of its supply as a result of the COVID-19 epidemic, and buprenorphine showed a continued rise during that same time. When we look at quarterly data here, it makes it a little bit more clear about the decline that methadone experienced following the onset here in Q2 of 2020, and that decline was sustained over a number of quarters that followed afterwards. In contrast, buprenorphine, the supply there continued to increase for every quarter, continuing up until the beginning of 2021. Here we'll look at medications for opioid use disorder as they vary by race and ethnicity. One study that compared buprenorphine and naltrexone fills based on these categories noted that there were some changes for buprenorphine as it related to race and ethnicity, but not for naltrexone. So specifically, buprenorphine fills declined for Black, Asian, and Hispanic patients, but that case was not the same for patients who were white. And in contrast, naltrexone fills during the pre versus post-COVID-19 period remain unchanged. Here's additional data showing the starts for buprenorphine as a medication to treat opioid use disorder and distinguishing among two different patient groups. Here in one group at the top, we have patients who were formerly on buprenorphine prior to the start of COVID-19, and had been on that medication for several weeks, whereas the bottom graph shows individuals who were newly initiated to buprenorphine as a treatment for opioid use disorder. On the top, we can see there's roughly no change for patients who were on buprenorphine in the past. In contrast, at the bottom, we see declines in terms of new patients who were initiated on buprenorphine after the onset of COVID-19. Here we see data in the Medicaid population. This shows us that there was largely no change in buprenorphine prescribing in this population when we compare the before versus during COVID-19 periods. But in contrast, there were decreases noted for opioid treatment program services, as well as the provision of urine drug tests during this time, suggesting that opioid treatment programs, which provide methadone, and urine drug testing were much more difficult for patients to access during this time, as opposed to obtaining prescriptions for buprenorphine. Access to methadone and opioid treatment programs also was an issue related to the onset of COVID-19. In the United States, roughly 1 in 7 clinics were not accepting new patients at the start of COVID-19. This rate of not accepting new patients did not appear to differ between programs that accepted Medicaid versus those that were self-pay, and the rates were roughly 14 to 15% for those groups. All right, we'll shift now and spend a moment talking about telehealth as it relates to the treatment for opioid use disorder. Here's data from the Veterans Health Administration related to use of buprenorphine, and it compared pre-COVID versus COVID times. On the leftmost portion of the graph, we can see that we saw declines in terms of the rates of per month patients on buprenorphine from the time period before COVID to during COVID, and then that rate fell up by about half. When we compare the groups of patients for individuals who are new initiates to buprenorphine versus those who were on it before, we see different results. And so we see the decreases were largely confined to the group of patients who were on buprenorphine in the past, whereas there was no change for patients who are newly initiated on buprenorphine. COVID-19 has had several impacts in terms of treatment for opioid use disorder. These have included challenges such as stressors, social isolation, and difficulties in accessing care, all of which were likely exacerbated in individuals who are more vulnerable. There are also a number of ways in which policy has changed to address those challenges, and those consist of three main areas. The first is Medicaid emergency authorities. In the second, there's been fewer restrictions on access to methadone after the onset of COVID-19. And third, there's been a policy change related to the use of telehealth as it relates to the care for opioid use disorder, and that includes the provision of buprenorphine. Let's unpack the Medicaid emergency authorities first. These are generally larger, broader programs that are not specific to the treatment of opioid use disorder, in which these policy changes after the onset of COVID-19 resulted in expanded eligibility and greater access to resources. This is not the first time that emergency authorities have been considered or that Medicaid expansion has been examined in the context of opioid use disorder. And past Medicaid expansion has been noted to be associated with increased access to substance use treatment, as well as declines in opioid overdose deaths. Here's one examination of a change in terms of the opioid overdose deaths from 2019 to 2020 as it relates to places where Medicaid was expanded versus non-expanded states. And you can see increases in terms of both groups, in terms of a comparison of the expansion to non-expansion states with the rates of overdose increases, suggesting that Medicaid emergency authorities were not related to declines or changes in terms of opioid overdose events. As it relates to fewer restrictions on access to methadone, SAMHSA issued a policy related to opioid treatment programs on March 16th of 2020. This provision had detail in it that allowed for more take-home doses, as opposed to requiring patients to be at an opioid treatment program and be observed as they take those doses every single day. For stable patients, they were permitted 28 take-home doses, and for individuals identified as less stable patients, they were permitted to have 14 take-home doses. So in a way, lowering the restriction on their ability to access methadone. Well, in one small study here, we can see that among stable patients, this policy resulted in an increase in take-home doses, roughly doubling in the time period from before versus after COVID. So having the intended effect of increasing the access. One of the concerns was, were there any increases in negative outcomes as a result of increasing this access and being more permissive with take-home methadone doses? No increases in negative outcomes of emergency room visits, overdose-related ED visits, or changes in terms of urine drug screen results were identified in the population, suggesting that overall patients were not harmed through this change in policy. We'll turn now to speaking a little bit about the use of telehealth in the care for opioid use disorder. How did this occur? Well, expansion of a remote treatment took place through the Drug Enforcement Agency issuing policy on March 21st of 2020, followed quickly by SAMHSA updating their policy roughly a month later on April 21st of 2020. Combined, these two policy actions allowed for the prescribing of buprenorphine without requiring an in-person visit, which was the case prior to this time. What was the result of such a policy action? Well, here's data that looked at patients in the Veterans Health Administration and looked at their retention and treatment at 90 days, comparing the time period from before versus after the onset of COVID-19, and specifically looking at treatment retention as it relates to the use of telehealth. And here we can see the top bar showing greater treatment retention with any use of telehealth at all. That could have been a telephone visit, as well as a virtual visit through a video system as well. Here we see greater retention, and the retention was actually even higher when video visits were used among those new to buprenorphine during COVID-19. Other ways to look at retention and treatment are the provision of how many days supply individuals have for these medications for opioid use disorder. And again, in the veteran population, we saw an increase in average days supply for buprenorphine that was studied. Before COVID, this number was about 203.8 versus afterwards was just 208.7. And while these changes may seem small on a population level, it certainly signifies an increase in access. During the COVID period, it was noted that individuals had 20% or less in-person visits during that time, again, reinforcing the reliance on telehealth to help care for patients with opioid use disorder. Another way of looking at retention and treatment is looking at individuals who have access to several days of their medication. And here, a measure that was chosen was roughly 80% of the days of medication available. Among Medicare beneficiaries, telehealth services were associated with increased odds of being retained on their medications for opioid use disorder, with an adjusted odds of around 1.3. When we think about telehealth's impact on overdose, and we look again at Medicare beneficiaries, here we see that telehealth services during COVID-19 were associated with decreases in the odds of overdose, so a reduction in an unfavorable outcome. So the impact of COVID-19 on treatment for opioid use disorder has resulted from a number of policy changes. On a very broad level, we saw Medicaid emergency authorities expanded, with variation among states in terms of how they did that. Second, we saw fewer restrictions in terms of individuals' access to methadone for those who are in opioid treatment programs. And third, we saw telehealth for the care of opioid use disorder, and in particular, this focused on the provision of buprenorphine. While these three policy changes were enacted during the COVID-19, and we examined preliminary studies related to outcomes related to that, we want to recognize that the road ahead may reveal additional studies that shed greater insight in terms of the impact of COVID-19 on the opioid crisis.